Okay, so I'm back to being a clinical professor in the program. I'm still teaching, but back in the on the volunteer faculty side of things. And as Randy said, I was president of ASAM a good while ago, a dozen years ago. So happy to be back and happy to be sharing some thoughts with you today. I do have a lot of disclosures. When I left full-time work in 2018, I got into my consultation business and expanded it. Just got on the Speakers Bureau of Vivitrol this week. I do work for a drug lab, Ammon Labs, that does the kind of lab work that would be wonderful if UW would use it. So I do have a lot of things, but none of them really have anything to do with today's presentation. There's no disclosures that really affect the talk today about peer support. So here's a framework for you. The interventions for addiction can include professional treatment and various peer support and recovery activities. The professional treatment, we're certainly talking a lot about pharmacotherapy these days, medications for opioid use disorder, alcohol use disorder, tobacco use disorder. And then psychosocial counseling remains a mainstay in professional treatment. But outside of professional treatment, there's working with peer support groups like AA and Smart Recovery, and then working with a recovery coach, which now is becoming a sort of a blend a little bit. There's a little touch of professionalism now in the recovery coach movement. And there's the use of health insurance to pay for recovery coach services that would never be used to pay for Smart Recovery or AA. So recovery coaching is a little bit of a hybrid between professional treatment and peer support, though I would say it's still maybe 3-to-1 peer. So there are questions you can ask. Does adding pharmacotherapy to psychosocial treatment in persons with OUD improve outcomes? Well, heck, think about the amount of time we spend on this. And as Randy was mentioning, we're doing more waiver courses to train people to use buprenorphine. So, I mean, I think the verdict is in. Adding meds to psychosocial is extremely important in OUD. What about the flip side? Does adding psychosocial to pharmacotherapy improve outcomes? That's a confusing area now. There's an article by Tom McClellan that's back in 1989, and about looking at methadone programs with a little bit of psychosocial, more psychosocial, and he found the more psychosocial, the better the outcomes in methadone treatment. And that's been sort of people thinking, well, that's just kind of common sense. Everybody talks about using the combination until David Filene and others have been publishing articles saying, we just can't find any improved outcome by adding psychosocial to buprenorphine treatment. So it's kind of interesting. So yes, there's two different kinds of professional treatment, the psychosocial and the medication. But what about the other things? Is professional treatment the only path to recovery? If you gathered together 100 physicians in recovery, you would find, I would think, at least 10 that never gone to professional treatment at all. They'd gotten sober through AA only. It does happen. And patients get sober through AA only. This is the question of today's little presentation. Does adding peer support to professional treatment improve outcomes? And I did a lit search and I found some data on this. Now, where is my slide? No, I didn't. I cut down the presentation. The original one's going to be a grand rounds at some point because it's a lot longer than the time we have today. I have a slide on names to look for if you're looking for evidence about efficacy of AA and NA. John Kelly at Harvard is one, Keith Humphreys at Stanford is another, and here they are together in an article just this year. I think it's even not even be in print yet. This says mutual help programs. They're definitely non-professional. They're peer-led. There's sometimes some sort of host that leads the meeting, but they provide emotional support. They provide role modeling. People can learn practical coping strategies. This is what peer support is. And again, I've got a list here that your AA spinoffs include all sorts of things, not just Cocaine and Heroin Anonymous, but Gamblers Anonymous, Overeaters Anonymous, Sex Addicts Anonymous, Nicotine Anonymous, swings back to substances. So non-professional treatment is for recovering people, offered by recovering people without a professional to lead the group. No money, no charges, no charts, no documentation, not professional. And one takeaway is it should not be in a treatment plan from a managed care company, go to AA only without professional help. That's a managed care company trying to not spend money, and that is totally unacceptable. There was a policy statement from '97. ASAM has been in this gig the last several years, and I'll be very clear that I'm not happy with it, of sunsetting policies just because they're old. And this is one that got sunsetted that has no business of being sunsetted. I'm going to try to get it brought back. It was a joint venture of AAAP, APA, and ASAM to say that patients in need of alcohol or drug-related disorders should be treated by qualified professionals, but self-help groups are also valuable. And insurers should be aware of the value, but also the difference. Self-help should not be a substitute for professional treatment in a professional environment. So a discharge plan from a hospital shouldn't say only go to AA. And so in the ASAM definition of addiction, we talked about peer support activities, mutual support, how it can be important. And we said that recovery from addiction is best managed through the combination of doing what you can on your own, getting help from peers beyond yourself, and then going to a professional who's actually trained and certified and not a charlatan. And if you find an ASAM certified or ABAM or now ABPM certified doctor, that person's going to help you out, and a certified addiction counselor, et cetera. So again, this gets back to the notion that integration of everything gives you the best results, but does it really? Do we really need to add things to just medications only? Now, I took out of the great resource Wikipedia a very fine definition of recovery coaches, and you can look it up yourself. Again, it's unlike most therapy because coaches don't address the past, they work in real time. It's just very pragmatic. This is how you stay sober today, and this is how you get support from others today, and this is how you build relationships today. And I'm an example of recovery, and you might be well served if you would do what winners do. So I've given a grand rounds already on 12-step facilitation. This is actually not going to AA. 12-step facilitation is professional treatment. It's a specific treatment modality. It's one of the 3 modalities in Project Match. NIAAA actually developed treatment manuals for everything to train the clinicians in the huge Project Match study that's now over 2 decades old. So it's an evidence-based practice. And what does it involve? It involves in every session checking on the person's behaviors. What are you doing? What are you doing to stay sober? The way I phrase it when I meet with people is, what is your recovery plan? And somebody who tilts their head sideways like a dog who doesn't understand what you're saying to them and is like, doesn't have a clue what you're meaning when you say, what is your recovery plan? That person's got a lot of needs, because anybody in recovery should know what their recovery plan is. It may include peer support. When you check in with people in TSF therapy, you actually use numbers quite a bit. How many meetings? How many sober days? How many slips? You get very explicit. How many phone calls are you making? How much reading of AA literature are you doing? How often do you talk to your sponsor? What number of the step are you on? And you get really, really specific. You sort of get in their face about it. And it's a very behaviorally oriented therapy that says, we're not here to figure out why you drink. We're not here to contemplate your navel. We're here to help you stay sober. And that requires doing some very specific things. So you probe for responses when people aren't doing things. Why aren't you going to meetings? When you go to meetings, why don't you talk? How come you haven't gotten a sponsor? What are the barriers? Let's identify the barriers to what you need to be doing behaviorally. And there's a gradation of involvement in 12-step activities, and TSF can probe that gradation. So the first thing is to show up. That'll give you some improvement in outcomes. The next thing is to actually participate and not just be silent. The next is to get a sponsor and work with your sponsor. The next is to actually work the steps in the big book, the 12 steps. But it's really interesting, and I may have a quote from one of the articles. It's the activities, somebody that goes beyond the first 4 bullets on the slide to the next 2, that's really correlated with success in treatment of addiction. People that are involved in their club, they do chores, they volunteer, they decide, they say, yeah, I'll be the general service representative to my city's intergroup, which is just like a clearinghouse for all the groups in town and publishes the schedule online. I'm going to do stuff. I'll go to retreats. I'll go to conventions. I'll go to social activities. NA, especially for young people, has. Did you know that NA has in WICIPA, the Wisconsin Council for Young People in AA? Did you know that they have whitewater rafting on the Wolf River up by Peshtigo as an outing for sober fun? And people that take it to that level really have the best outcomes. Here's the slide I had. So these are the people you look for. Leanne Koskoudas, who got the Smithers Award, gave the Smithers Distinguished Scientist Lecture at ASAM 13 years ago. She's at Berkeley. Rudolph Moose won the Smithers Award a year before that. He's from Stanford. He's still doing some writing, I believe. He's got to be in his 80s. John Kelly is at Harvard. Keith Humphreys, I mentioned, at Stanford. And Mark Gallanter at NYU. All are excellent in the literature about research into AA. So here's this article, October 1 of 2020, very recent. I think it's not in print yet. So they found that if you're going to more meetings, there's a better chance that you're going to reduce your use. It was very interesting. What they found is that TSF techniques work to get people with alcohol use disorder to go to AA, but they're not that good at getting people with drug use disorder to go to NA. And they weren't quite sure why of that, but some of their hypotheses were that people with drug use disorder may just have more complex lives, more psychosocial variables, and less recovery capital. And it's just going to be a tougher road for them. So this particular article, a 2020 publication, looked through a Cochrane review of 27 rigorous studies, and they found that, yes, AA works. Strong relationship, linear association, 1-year follow-up with a number of groups attended. And they looked at some other articles. They cited a Roger Weiss article that participation predicted reduced cocaine use, and again, not just going to meetings. And then a key predictor of interest was 12-step group attendance by drug use disorder patients. Again, one of the ways you measure outcomes is reducing the alcohol score or the drug score on the ASI. And as I've heard Tom McClellan give lectures on this many times, your physicians in recovery have great results because of the intensity and duration of treatment, but they have very high scores on the drug severity score. A doctor's shooting up every day. They may have very high drug severity scores, but like psychosocial is very low because they're high socioeconomic and they have a stable family, et cetera, and a job to go to. And they have better outcomes, and the people with rough outcomes are those who have high ASI scores on all the psychosocial variables, so the social determinants of health. But TSF has limited ability to help drug disorder patients. I found that really, really helpful. My hypothesis is that those with OUD on meds may face stigma when they go to NA. And that's been reported in all sorts of articles. And that's where Heroin Anonymous came from, was because if people disclose they were on meds, they sometimes get a lot of flack at meetings and from sponsors and from family members and all sorts of stuff. This particular article was interesting because it had a lot of qualitative data, patient verbatims, and they did cite the Ted Parent article that said the most common reason for people stopping meds was they'd go to 12-step and get hassled and be told your recovery is not legitimate. So it's a real issue. And a lot of people find that running groups, I know some of you know Ian Powell from the years he worked at New Start. He went to Rogers a year or so after I did, working at the Milwaukee campus in West Dallas. And he found with his buprenorphine patients, he just set up a separate IOP and separate recovery groups, just so there wouldn't be this issue of other people in group hassling those that were on meds. And so having a Heroin Anonymous meeting may be more effective for people. Here's an article from 2015 looking at people in Baltimore, one in an FQHC, one at a community mental health center. And 2/3 of them reported that NA was very helpful to them, and only 5% said this didn't help me one bit. And there was a correlation between overall outcomes and attendance. So another article that you can find. Here's an article, another one from hot off the presses, 2020, Psychosocial Intervention, Utilization, and Outcomes. And this found that the more psychosocial and the more 12-step, the better the outcomes. The hours of counseling and the hours of 12-step participation predicted better outcomes. And this was a study looking at 8 different treatment centers. And as is pointed out, they're free and they're ubiquitous. And, you know, I love smart recovery, but I always say that smart recovery has not won in the marketplace of ideas because they're not as common as Starbucks. But AA is as common as Starbucks. It's all over the place, and unlike Starbucks, it's free. Back to the Monaco article. According to NA World Services, methadone patients are this is the qualitative stuff. People said, this is NA World Services put in writing. Don't mention methadone when you go to NA, so you don't end up in a conflict with peers. Isn't that fascinating? The World Services of NA advises people. They don't say don't take meds. They say don't talk about it. Isn't that interesting? So again, I've got a lot of stuff here from the literature. We're close to being out of time. Dugash has the best review of psychosocial interventions in conjunction with MOUD. The Filene article, a Walter Ling article said adding psychosocial doesn't make a damn bit of difference. But I think a lot of people still believe that psychosocial added to meds helps. And again, Harvey's work was adding 12-step to medications and found that it does help. And she quotes all sorts of studies by the classic group of authors that I mentioned. So let's see these last few things. What can a doctor do? I think regular advising your patients that AA exists and advising them to go is good. Keeping schedules printed out from the web and keep it in your desk drawer and hand it to patients. This is your schedule. If there's a First Friends program in your area, having somebody that you can call. And recovery coaches have sort of taken over the role of First Friends, of having a recovery coach come meet with the patient and take them to their first meeting. Realize that TSF is more than just saying go to meetings. It's actually engaging with the patient in some of the ways that we talked about before. How do you learn more about it? I think experiential learning is the way to go. Go to a meeting yourself. If you look at the schedule, you'll see open meetings listed, and if it's not, then it's a closed meeting, which means it's only for people in the fellowship. And you will have trouble getting into a closed meeting just to be an observer. But one of the places you can learn is by going to a health professionals meeting in town. They're definitely closed meetings. But if you talk to the leader of that group, they want doctors to know more about this, and medical students and residents. So even the Dry Docs meeting in Madison will welcome people just to learn. And you can learn a lot more than by going to open meetings, which are often just speaker meetings. So I did get done in the time available. And that was the presentation.
Great. Thanks so much, Mike. And I do see a number of folks still on with us, so let's pause and see if people have any questions about peer recovery and Dr. Miller's presentation.
Can I ask where we would recovery coaches, and if there's any formal organization that has listings or?
Well, I don't have answers to those specific questions, which are wonderful questions.
Joe does.
We do have somebody, but I would say that recovery coaches have gotten more traction around the opiate epidemic, and funding for expansion of training for recovery coaches, again, comes from opioid monies. And so the ED to recovery programs that have been established throughout Wisconsin were intended to help people to meet with a recovery coach if they present with an opioid overdose in an emergency department. And so in Dane County, recovery coaches are done through Safe Communities. And their Safe Communities, there's a website right there, or an email address for Joe. So in Dane County, Safe Communities is where there's the big collection of recovery coaches. But again, in the ideal world, it wouldn't just be related to the opiate epidemic. Recovery coaches would be for everybody with addiction. Ritu, did you put something else on there as well in the chat?
Yes, so there was a question from Amy Perrins around using them inpatient, and that is something at UW Hospital that we've used and has been a really nice resource. I know there are others on here that could comment more on that. They can assist with recovery as well as navigation with follow-up and things, and that's been a very nice resource.
I would direct people to Wisconsin Voices of Recovery, which is now housed, and there's their link, is now housed in the Department of Family Medicine and Community Health. So Wisconsin Voices of Recovery has a grant to bring the ED to recovery concept throughout the state. And again, this is opioid money, and it's a shame that that's it, but we'll take the money. All of addiction medicine needs the money. I would think that they would know about recovery coach resources in different communities. But in Dane County, if you call Safe Communities, if you're at Meriter, St. Mary's, Stoughton, any of the hospitals in town, you will get a recovery coach to be able to come to the patient's bedside. And I think the natural path beyond this is coming to an ambulatory site. And I think there's probably going to be some primary care docs who are going to be inviting recovery coaches to their offices to meet with patients. And I think when Dr. Kalpala goes back to Mayo Clinic in Eau Claire to his family practice after his year of fellowship, he's probably going to be a role model of inviting recovery coaches into the clinic building. Again, we used to do this through First Friends at AA, and that seems to have faded out. Any other questions, Randy, that you see?
I believe, Joe, didn't you start doing, in that very role quite recently, being on site in a primary care clinic?
Sure, I'll make it real quick. So I'm going to be the peer support specialist supporting waivered providers in primary care clinics that are prescribing for opiate use disorder. We're part of a team, so they're going to have access to me, the peer support specialist, the behavioral health clinician, the primary care provider. So I am actually kind of working alongside of some of Dr. Brown's fellows now in clinic. And it's been great already. The doctor's already made warm handoffs. I'm there in the clinic. I sit with the patient, and then I can help them with those unique needs outside of the clinical setting, whether it be court appointments, CPS appointments, other resources. It's a wonderful program.
That is really wonderful. It's great to hear that's happening, and here's hoping it's something that grows quickly.
Joseph, is it only in Madison? Is there anywhere, will you be available in the Waukesha or Milwaukee area?
Recovery coaching and peer support is around the state through WIS Voices, but the Hub and Spoke project right now is just the Test to Change clinics, which is Yahara and DeForest Windsor. Possibly northeast to come. The hub would be behavioral health and recovery, so we can refer up to a higher level of care. And then hopefully outside agencies, internal medicine, Randy's team can also refer to that level of care.
Joe, I really hope that you guys have the money and the time and the resources to write up everything you do and fill the literature with stories of how to do it, and so that people get hope and courage to try it in their own communities, and somebody in Ohio or Alabama picks up the article or picks it up off the web. We need to get the word out that these things are doable. It's not an insurmountable challenge. And I'm so delighted to hear all the great things that are happening through Wisconsin Voices. Laurel, did you have something?
I need to ask, is it only opioid? I mean, I've dealt just in the last 4 months with 4 people. One has died from the heroin overdose, or actually 4 overdoses.
We got a lot of epidemics going on. We got methamphetamine, we got alcohol, we got cannabis. So addiction is pretty broad. The issue is that nobody in government really paid a damn about this until the opiate epidemic hit. And so the money is all attached to opioids. But all of the concepts apply across the board and should be used. So Joe knows what he's doing. He is absolutely not going to refuse to see a cocaine patient. So yes, it's set up through an opioid funding stream and grants, but it's useful for everybody with addiction.
And I'll just chime in real quick. So peer support recovery coaching through Safe Communities, since we're funded a lot by the county itself, and we have different funding streams, we are open to alcohol use disorder, methamphetamine, cocaine. If there's a problem, somebody has an issue, they can call that number that was posted. Instantly somebody will answer whatever they're struggling with, they will get help with.
Right. And so I really am glad we had the opportunity to put this into the ECHO format and get the word out about recovery coaches, peer supports, and just good old-fashioned NA and AA. They certainly can make a difference for people. They're not for everybody, but they have a lot of success for a lot of people.
Great. Really rich discussion. This was really a great session. Thanks so much, Kelly, for the case, and Mike for your presentation, and Joe for all the information on what you're doing.
Thank you, guys.
And that resource, really great. I'm sure a lot of us have another thing to pivot to at 1:30. So in the interest of self-care, being able to have a little bit of a break from all our video meetings, I think we'll wrap there.
So, Randy,
happy holidays and New Year, and we'll look forward to seeing you in January.
I'm going to tell you what I'm going to pivot to. At 1:30, I have an appointment with a patient of mine who's an RN who went to detox, then residential, then IOP. She's been with me. She's been sober 7 years. And this month, we're going to go to the nursing board to take her off of monitoring. Recovery works and monitoring works. And she's an ICU nurse again, and she's been practicing in the Aurora system because they're very welcoming to recovering nurses. And those are the kind of stories we all need to be faces and voices of recovery, even if it's vicarious. It's my patient, it's not me, but that's what my 1:30 is.
Wow.
Thank you.
Merry Christmas,
Thanks so much, everyone.
Bye, everybody.
Be well.
Thanks, Randy. We'll see you.